All right, so we'll go ahead and get the show on the road. Well, good morning, everyone. This is Jomo Stewart here at the Fairbanks Economic Development Corporation. It's Tuesday, October 5th, Municipal Election Day. So I hope everyone makes time to do their civic duty, exercise the franchise today. It's important. But something else that's equally important and probably a lot more pressing right now across our community, across our state, our nation actually, is COVID-19 and how it is impacting our healthcare system and the things that we might be able to do to help make things better for ourselves, our families, our friends, our neighbors, and our community. So we do have with us Doctors Ramirez and Dr. Nace from over at Foundation Health Partners. We also have Mr. Jeff Cook online, who also is affiliated with Foundation Health Partners. But again, to give us a presentation regarding COVID-19, the Delta variant, and how it's impacting our community and our healthcare system. So without further ado, if I may, I'll go ahead and hand over the mic to the doctors. Please know, as was just stated, the chat line is open. If you have questions, you can lodge them there. You can also take yourself off mute if you have any questions. They've been prepped as to how we operate around here. But if you have any specific questions, I think you said regarding crisis care. Go ahead and we'll get those. Right. We'll kind of front load those because Dr. Ramirez is going to have to go off to do saving lives. Okay, so without further ado, doctors, please, the floor is yours.
Okay, thank you so much for having us. Dr. Nace and I will be doing this presentation jointly, and we may flip back and forth, but for the most part, I'll be covering the first half, which is a little bit kind of what's going on in Alaska, as well as what's going on here at the hospital. And then she'll cover a little bit around kids and pregnant moms. And I think the most important thing, what we can all do to actually address the current crisis, because it really is going to take everybody working together. It's the only way. And I think that's one thing that's just very striking about a pandemic. It's really not so much what we do inside these four walls of the hospital, but what happens at a larger community level that makes a difference. So next slide. We'll get started. Huh. Can you move the slides, Michelle, or?
I am trying to tell it to.
Okay, just want to make sure I wasn't
Maybe try it from your angle, then pull it up on there. It's not responding. Oh, there we go.
Oh, there we go. Okay.
There you go.
So hopefully this will work. So this was a flattening the curve slide that was all over the news a year and a half ago. The point of this slide back then was to show the public that with a new virus where nobody had immunity to it, where we didn't have a vaccine, that if everybody got sick at the same time, we could overwhelm the healthcare capacity. And that was why we had to flatten the curve. And that's why there was that shutdown in spring of 2020. Since then, we've learned a lot. We've learned masking works. We've learned how to distance. And since then, a lot of people have developed immunity. But the reality is, it is still such a new virus that if everybody gets sick at once, it can overwhelm the healthcare system. And that's kind of what we're facing here right now in Fairbanks. Next slide. So this is kind of like my favorite slide, and it's really moonshot, like something that's incredible. And I think the development of the vaccine in our time, in that time period, was a phenomenal effort, and one that was really not anticipated, that we would have something so effective, so safe, so quickly. And I did not anticipate it, and I think many others did not. But I think while we were all worried about PPE, we were all worried about test availability back in spring of 2020. We were worried about, what does all this mean? And everybody was scared, including all the clinicians. The scientists had gone straight off to work. As soon as the virus was discovered, the genome was sequenced, they started immediately working on the vaccine, and they kept working on it even as we were all busy on other things. And then lo and behold, I think that was to their advantage that they were able to work out of the public eye and kind of do their thing, to get it done. Next slide.
If I may,
Yes.
my understanding also is that, again, they've been doing quite a bit of work on coronaviruses for a
Yes.
while. And so really, it's not that it just miraculously got whipped up, within 12 months. It's just that there have been years and years of advanced work done that allowed them to create a vaccine in that timeline.
Yes. I mean, you actually read my next slide in advance.
Oh, okay.
No, it's perfect. It's perfect. And for me, this is my personal connection to the vaccine. So this is a timeline that actually details out the activities that have been the science of the coronavirus vaccine. And they actually predate my child's birth by about 10 or 15 years is when the science actually started. My child was born in China, and it's just my own personal connection to the coronavirus. And we adopted her, but our adoption was delayed because of the first SARS-CoV-1, otherwise known as SARS. And that was when that epidemic started. And that was really when things really started picking up pace in terms of the vaccine research work. So back in 2002, and they really had developed a lot of that research work from that time period. And there were multiple attempts to deploy it for other viruses. And Zika was the one that I really recall when that came up. But the problem was it actually never got to the point of, they started work on it, but they actually never deployed anything because all of those epidemics just resolved and went away. But so the research and the work continued. And so they had this whole background. And like I said, my daughter is now 18 and she's a freshman at UAF. And so she's my marker of how I always know they've been working on it for 20 years of solid work and had it ready. This year's work was really focused on just this specific virus and this specific genome and actually testing. So most of the year was spent in actually doing testing because all the science work had been pre-done. Next slide. So Delta virus is different. There's no way around that. And it's a variant, and we have variants because we have spread and viruses mutate and they change. And they select out for the survival of the fittest. And so, the Delta virus, so the chart up on the left is genomic sequencing, and throughout the world, throughout the US and in Alaska, but actually this is where Alaska has stood out. We have done so much more genomic sequencing than anywhere else in the States. And a lot of it is done, or almost all of it in Alaska is at UAF. And so they can sequence the viruses. And what has been shown is that in recent times, past several months, almost like 99% of the virus in the US is the Delta strain. The big difference with Delta is that it's far more transmissible. And the chart below, you can see that when the original, the influenza virus typically affects 1 to 2 people. And that's how it continues to spread. The original COVID-19, the estimates were around, without distancing, without any of those interventions in place, maybe 2 to 3 people would generally be infected by every 1 person. Again, that's how it continues to spread. Anytime you're infecting more than 1, you get propagation of spread. What we had here in Fairbanks, back in April, May, we had a spike of cases, and that was the Alpha variant. And that's on the upper bar to the right. And you can see that was estimated at 4 to 5. What's different about Delta is the estimates are more around 8 people can get infected by each person transmits it to 8 people. That's, again, without distancing, without masking, without any interventions. That's just an incredibly high transmission rate. And so it spreads incredibly fast. The other thing that we have seen with it clinically is that symptoms tend to show up very early with Delta. A lot of that has been attributed to one of the findings with Delta is that the viral load is so much higher. And it's thought that that's what's creating the ease in transmission and the a rapid onset of symptoms. So, even though, it's still COVID, because of that, it just behaves differently. And because of that, it's become the dominant strain. Next slide. So I just spoke about all the ways that Delta is different. The flip is, there are things that's still the same. And one of the points that I really want to bring home is that the vaccine still works. And so this is data from Alaska, and this is looking at two groups of people, whether you're fully vaccinated or you're not fully vaccinated. So the blue bar is not fully vaccinated. And you can see when you're just looking at hospitalizations, serious illness, and that's usually the standard that's applied for vaccines. When you're looking at that level of illness, you can still see that the risk is significantly less if you're vaccinated as compared to as if you're not vaccinated. So even though Delta is different in that it's much more highly transmissible and that it can present clinically with symptoms earlier, what is still the same is that the vaccine works. Next slide. So this is hot off the press. This has not yet been distributed and it's still being kind of vetted internally. But this is data from Fairbanks specifically. We have gotten a lot of questions from the press, a lot of questions from our community about what are the rates here in Fairbanks between unvaccinated, for hospitalizations between unvaccinated individuals and vaccinated individuals. And so we had looked at it previously internally a number of times, but quite honestly, it is a little bit of a labor of love. But because of all the questions that we've been getting, we devoted some of our quality performance improvement staff to spending the time in terms of going through the chart reviews and looking through Backtrack, et cetera, to have this information so that we can share it. Because of the interest and because people, I think it's the reality. We can talk about science and we can talk about information, what's happening elsewhere. But people really want to know is what's happening here. And that brings it home to people. So we wanted to make this available. So if you look at this, our chart pretty much says the same thing as all the other charts, that if our hospitalizations are overwhelmingly the unvaccinated individuals, and when you get to ICU and ventilators, that becomes even more true. The green little people are represent vaccinated individuals. What I can tell you is what we are clinically seeing is that the vaccinated individuals who are hospitalized fall into two categories. One, being immunocompromised, organ transplant, active cancer patients on active chemotherapy, people who we would not expect to mount a full immune response. That's why a couple months ago, the CDC and the FDA approved and authorized that third dose of vaccine for that group of individuals. The other folks that we see in the vaccinated people who are hospitalized are the frail elderly, the old. And unfortunately, we see some of those in that deaths category as well. Only recently did the CDC and the FDA authorize a third dose in that population. We've been seeing it since April. It's been clear that population has needed a third dose. I will just leave it at that.
Dr. Ramirez, how
Yes.
would you define old?
Oh,
If I'm
so sorry.
approaching 78, I just want to know where I fall.
Yeah. So the CDC and the FDA authorized it for over the age of 65, which I am getting to myself. I will say, in speaking with Dr. Creighton, the youngest person that we have seen here die is 77. So we've been waiting for that authorization. I will just say, from a clinical perspective, we've been waiting for that authorization for a third dose in that population. And I will say she's been one of the strongest advocates for it. It's just based on what we've been seeing. So, but this is our data.
So Dr. Ramirez, if I'm reading this right, it looks like if you're unvaccinated, you're 4 times more likely to be hospitalized, 8 times more likely to go to the ICU, 4 times more likely to have to go on a ventilator, and 4 times more likely to die. If I'm reading this correctly, as compared to a vaccinated person. I do wonder from your statement regarding the people that have, the vaccinated people who are having the worser
Right.
outcomes
Mhm.
are people who are vulnerable, either because
Yes.
they have other medical conditions or age, some level of increased vulnerability.
Yes.
Is there going to be a breakout, or could there be a breakout that showed of this number of the vaccinated, those who you would consider otherwise healthy, who should not be having possibly this such a severe reaction?
So we had not planned on that, but I think we could take a look at that as a snapshot. And again, I think we are happy to invest time and energy in anything that helps make this real to people here. So if that would be helpful, like I said, the general gestalt is that, yes, it's folks, and quite honestly, to the other question about age, it's not solely age. It is truly age with multiple comorbidities. And it would be helpful to get that documented. I'm going to be really frank here. All of that takes time and energy. And right now we are strapped for that. So
Your time is being better spent, ma'am.
well, we're trying to balance where to spend all the time. That's it. And again, I get it. All this data is available at a national level. I also get it though. People want to know what's happening here. That's when it becomes real. And that's why we invested the time to get this done. And it was a partnership with ASHNA to put it in a pretty infographic. And we can get those numbers for you in terms of trying to calculate risk. The only thing is I would caution is usually when numbers are this small, we don't like to put estimates of risk attached to it. I think the visual hopefully could demonstrate to everybody that the risk is far higher if you're unvaccinated. Again, we hate to put numbers to it without much larger sample sizes, would be the only caution I have.
It certainly comes through for me.
Yeah. So hopefully you'll be seeing this out and about a little bit. Like I said, we're still vetting it, but we're hoping to release it very soon. So you guys got a preview. I always like to give a preview to when there's a special audience, special request. So next slide. So this came from an op-ed in the LA Times. It was just a really well-written one, and it really resonated with our clinicians here and our respiratory therapists. And it really walked through the 7 stages of severe COVID-19 and what the disease looks like on a clinical side in-house. Next slide. And Hawaii, the emergency management program in Hawaii, took that op-ed that was in the LA Times and changed it into a slide set that's available online. It's about 7 slides. These are just the first couple slides, but it's telling the story from one respiratory therapist's perspective and what that person sees on a regular basis in the hospital. And it becomes a pattern, but it's a pattern that's not evident to people who are outside the hospital, but it's very evident to anybody who works in the hospital. And yes, we do get vaccinated individuals in the hospital, but almost always their COVID-19 infection ends after stage 1. The next slide. And so stage 1, people can get sick, and we see this as on an outpatient basis as well. People can get sick to the point of feeling like they have the flu. And sometimes people, usually again, people who have other comorbidities or who are older or immunosuppressed may end up having to be hospitalized, but usually still it's at the stage 1. They need some oxygen, they need some treatment, but then they get better and they go home. I don't have in here the slides from the other stages. And in a previous presentation, we shared Amanda's video But I think that's pretty widely available now. And that's one of our nurses who's on the floor. And she just, and if anyone here who has not yet seen it, I would strongly encourage you to see it. It's on our website and it's been picked up by a lot of the news media. But it's her personal story of what she sees in these later stages and how people die and the feelings of guilt and the feelings of air hunger and the discomfort that people experience. And again, it's complicated by this feelings of guilt, feelings of regret from family members who sometimes it's family members who encouraged the patient not to get vaccinated, who now feel guilt that they did that. She also talks about having to take care of spouses, husbands and wives, and one going home and one dying. And that is something that almost every day on the board in the hospice room, we have a couple in-house. And it's just very, I don't know. It's very challenging for the staff and everybody. And even myself, who's a little step removed from it, anytime I'm in the rounding room and kind of see that, it just kind of hits you because that's just a hard thing. This is just a nice description of it, of something that's not so nice. And then Amanda's video is a very personal telling of a story. Next slide. So vaccination rates, at the end of the day, what gets us out of this is immunity. I would much prefer if we all did it the vaccine way. It's far healthier for our community, I think, long term. We're going to see a lot of long-term pulmonary disease, and we're starting to see that now in our clinics from people who've been hospitalized and recovered with COVID. They don't go back to normal lungs after it. So I personally, as a clinician and as a resident of this community, would far prefer that we see it through vaccine-induced immunity. But at the end of the day, it's only going to be immunity, whether that's infection-induced or vaccine-induced. But this is our vaccination rates. I was kind of happy. They look like maybe they're starting to uptick a little bit. We are still very much in the low vaccination rate for our community. So it's sitting in the 50% range. Next slide. So this is from a dashboard that our staff look at all day long, every day in the ER. They actually have it out. And when it changes, they post a difference. We don't think about it a lot, but our hospital is part of a larger system. We function because we can take care of a lot of things here, but people have our back. When certain conditions, patients with certain conditions need specialized care, we're usually able to transfer either to Seattle or within Alaska, Anchorage. That has been a challenge lately. And this is what we see frequently. Many places are closed. On that particular day, we were near capacity. We have been near capacity frequently. The past 3 or 4 days, we've been closed to transfers. And sometimes, and I think the reason why the clinicians all use this dashboard as opposed to the other one out there that has the bed capacity from the state is this one is manned by the clinicians, the house supervisors or the transfer centers who are boots on the ground, because every patient is not the same, every bed is not the same, every staff member is not the same. So sometimes we may have a couple beds open, but if we don't have staff to handle those beds, we have to close. Sometimes it's the acuity level of the patients that we currently have. And when I use acuity level, I mean, some patients are sicker than others and require a lot of time and intervention. And if we have several of those types of patients, then even if we have other beds, we really are not able to take transfers. I think for us, we can't transfer out. And so we can't transfer to Providence or Alaska Native Medical Center or a regional. And again, this constantly is evolving and it changes throughout the day. Everybody's been, I think all the clinicians are used to working well together. And so everyone's been really good about flipping it, as soon as there's capacity, whether that's created by a death or whether that's created by a discharge home, or that's created by additional staff coming in as we are experiencing now with the FEMA relief. People flip this immediately to near capacity or to open. Everyone's been working together as a team in the state to, it's been the only way through it. Next slide. So this is a critical metric, our percent positivity rate. You can see our prior surges, our max was at 9%. This is the first clue that we're going into surge. The testing positivity rate goes up, the case rate goes up, the hospitalization rate goes up, and the death rate goes up. This is a pattern that we have learned over 18 months now, and we have become very familiar with it. So this was the first thing to go up. It's the fact that it's slowed down in its increase is great, but it's not coming down yet. So we've been kind of hovering 17, 18, 19% for about a week now. Our prior surges, we landed at 9%. What it tells us is that there's a lot of people out in the community who have COVID and don't know they have it. And so they're not quarantining. And with Delta, that transmission rate is so high that you just know that it's spreading, which is what we're seeing and facing. Next slide.
Actually, Miss, if I may,
Yeah.
on that last slide.
Mhm.
So again, there are numerous testing facilities around town.
Yeah.
So they feed this information somewhere into a source that then can compile it for this kind of presentation. Is that correct? And I see that
That's
the date is
correct.
October 4th.
I will say it's transitioning though, as more and more at-home testing is available. Not all of those tests are reported. So over time, I suspect this is going to get less and less reliable. And it's, yeah. So yes, it's all, everybody is required. We always have diseases that are required to be reported to public health. And every lab have laboratory sites. And so I'll report in, again, as testing has increased, we're relying on a lot of they're at home or in a setting. Those places are not, they don't have those electronic processes available to just automatically feed test results in. And so you end up with more and more delay. I think this is less and less complete, but it's still useful. Next slide.
Thank you.
Michelle? Thank you. So this is just a pictorial representation of our hospitalization rate. And again, you can see we had that spike in April, May. What we have right now is a surge that we've not experienced before. And, you know, and our percent hospitalization rate with COVID is running in the 30s for about a week now. Previously, our highs have been around 20%, and now we're around 30%. And it's just really relevant when you have that many COVID patients in-house. It just impacts how you function completely across the organization. Next slide. Yeah, so this is just a reminder. We all have surge plans. We all have plans of how to expand capacity. These are the three things that we always work on: space, staff, and stuff. And again, just a reminder, it's not as easy as just opening up another room and putting a bed. We have to connect that bed to all the services that make it so that it's not just a hotel room, but it's actually truly a hospital bed where someone's getting adequate treatment. And so aside from the staff, I have been really impressed or struck by all the IT work that has to be done for each one of these additional spaces to go live. But it's a lot of work, and we have that surge capacity. And I think we have some pictures coming up that show some of it. Next slide. I
Since we have a
can't
little
see.
delay.
Is Angie breaking up for you?
She had a little bit, but it cleared up
Okay.
on my end.
Yeah, I am so sorry. Usually I don't have that problem. I'm in my office. It's usually hardwired here. I can't
Actually,
see the slides moving. So I'm just gonna,
oh, it's okay. Dr. Nace, join.
oh,
There
here we
it
go.
is.
Okay.
We can,
Because I have the slides myself, I'll follow along if I can't see it. So these are where we've had service disruptions. And again, this is kind of a new term for me, at least. But, talking about it, every day it's a little bit different as to where we have service disruptions. And we're constantly monitoring these and trying to take action on them. So episodically canceling surgeries. Screening endoscopies were paused for a time. We are now actually doing those again. But we've had prolonged wait times in the ER and in first care. In the ER, it's episodic. We've had to put chairs in a hallway and have what we call chair patients. We don't actually see the people in the chair, but it's a place where people can wait for test results. Usually we've always had people wait in the room, but now we have them waiting in a chair for test results, et cetera. So we can use the room for somebody else not wanting to back up. First care has had wait times of 3 to 4 hours, which is not fun for anybody. We've had some problems with MR and CT scan scheduling, and we've actually had to shut intermittent closures of our CT scan located at TBC. Most of this is driven by staff and how we're having to use our staff in different places. Next slide. So staffing, we've really kind of had to get creative. We've had roughly 200 open positions within the system. And again, we are facing just kind of what is being seen across healthcare. I'm just going to put in a plug because there's been a lot of questions about our COVID vaccine mandate and whether we've been losing staff because of that. The report that we got last night was that we had 10 staff who chose to resign rather than get the COVID vaccine, which is less than 0.5% of our staff. 4 of those were actually per diems, PRN staff who didn't really work for us that much. And out of the other 6, I am told, I don't know this for sure, but I am told some of those were folks who were leaving anyway. And they just happened to, they chose that time to move on because they didn't want the vaccine. So the vaccine mandate did not impact our staffing at all. And we've been having to use staff in different ways. And so we have huddles for every day as to kind of where we're short and where we can move staff from this place or to that place. We are facing the same challenges that I think every business in town is facing in terms of staffing. Next slide. So this is a picture. Yeah.
Actually, Dr. Nace, on that last slide, I did want to ask, is there any way that non-medical professionals could be helping out on this or over at the hospital?
Yes, so that is one of our strategies, and we have what we call COVID relief positions, and we have been placing non-clinicians on the floors, and they've been acting as runners, they've been acting as stalkers, they've been filling water glasses for patients, they've been answering the phones. I think we still have positions available. Again, typically those had all been done by our clinical staff, and our nurses have really embraced being everything for the patient, but we've really been having to focus them on direct patient care activities. And so yes, anything, so non-clinicians can help as well.
And are these paid positions?
Yes, yes, yes.
Wow. One of the reasons I ask is, I mean, I do, I know some young people who are working young people jobs who might be putting their time and talents to better use than say, well, actually, I don't want to besmirch any particular class of business. Everybody needs people these days. But again, to know that if you have time, you could be helping out over at the hospital and the healthcare system, and it would be for pay.
Yes, and I would also put a plug in. I think it's a great opportunity for anybody who has any interest to just get exposed as to what healthcare looks like. And there's lots of just getting your foot in the door. It may pay a little bit less than someplace else in town by a few dollars, but the opportunities for learning and growth and development are phenomenal, as well as the benefits and the exposure. So there's lots of, I think it's right now is a great time for young people to have their choice. And I think this is a great choice and an opportunity to serve in a way that makes the community better. So yeah, whatever you can do to promote. It's the COVID relief positions, and they are both clinical as well as non-clinical. So this slide outlines, this is one of our alternate care areas for surgery patients to save on an inpatient bed. We have been recovering them in our extended recovery area. And I like to show this picture so that people understand that it's still very nice. You still have a private room. It's not, even though you're not on an inpatient bed on the hospital side, you're still in the perioperative area. We have a hallway with these private rooms that we have changed over into making them the recovery area. It is the only thing that's allowed us to continue doing surgeries at all during this period of time. Again, this is one of the areas though where it's a new area and we had to kind of fix IT to recognize it so that medications could be delivered, as well as food trays, things like that. You wouldn't think about behind the scenes that has to happen. But yeah, go ahead, Michelle, I'm sorry. This is the MAB corner. This is where infusions of monoclonal antibody were being administered. This did not exist a month ago. It's in our North Tower lobby with a nice, gorgeous fireplace. And it has a room with a view, even though the chairs are the wrong way. But so we were giving more than 20 infusions daily until we recently have had a shortage of the monoclonal antibody. And so right now we're giving about 10 infusions a day. We had to restrict that to high risk. Next slide.
Just a note on the monoclonal antibodies. So do they get used on patients generally, both vaccinated and unvaccinated?
Well, up until 2 weeks ago, yes. We used, it didn't matter your vaccination status. Because of the limited quantity now, we had to restrict it to only those who are at the highest risk for progression to serious illness or hospitalization. And so that criteria is for the most part unvaccinated, because like you saw in that chart, most people being admitted are unvaccinated.
Let's try this a different way. When you get the vaccine, it encourages your body to make its own antibodies.
Yes.
Whereas monoclonal antibody injections are giving you antibodies that were created somewhere else.
Yes.
Like the difference between getting your vitamin D from a glass of milk or standing in the sunshine.
Yes. No, you have it. So at the end of the day, this disease is your immune system. Our treatment is really based on supporting you and giving you oxygen while your body recovers, if it recovers. And for the most part, it's your immune system. And so the more that we can, if you have antibodies from a vaccine, it prevents you from getting sick with the disease. If you have, if we give you antibodies, these have to be given by infusion. They are antibodies that are made in a lab. And they are under the emergency use authorization. Yeah, no, you have it.
But they don't encourage you to actually produce your own antibodies.
No, they do not.
So a bit ironic that you might avoid the thing that could help you create your own antibodies so you don't get sick, and instead will defer to synthetic antibodies that you have to have transfused in. Okay, just checking.
Yeah, no, you hit on it. It's been one of the interesting things, and our clinicians at First Care, who've been probably, and the ED, they have been very struck by how people may not want to even have a conversation about the vaccine, but they are immediately engaged about getting the infusion of antibodies. I don't know what to say to that.
It's okay. I'm supposed to. I'm allowed to editorialize. Thank you very much.
You could compare it to the parable of teach a man to fish, you feed him for a lifetime, give a man a fish and you feed him for a meal. And that's monoclonal antibodies. We're just feeding him a meal, but we're not protecting him for a lifetime. And we'd much rather teach you to fish.
Thank you.
So next slide. So these are Tracy, and I'm blanking on her name, but there are some of the folks that stood up the extended recovery area within like 24 hours notice, had stood up the MAB infusion center. They are a few of our nurses. Our nurses actually have been incredible heroes throughout this whole process, and just really, and I will say we had a physician meeting last night, the PAC, where we kind of go over COVID protocols, et cetera. And Michelle was there. And last night, it was just really nice to hear, heard from several members, including Dr. Starks, just volunteering how phenomenal the nurses were and how they stay compassionate, even as, particularly this weekend was a bad weekend. People were just very stressed. And Dr. Bruner said the same thing for the Women's Center nurses. Our nurses have just been champs through all of this in a way that you don't see every place. A lot of places, I mean, even as they're busy and focused and everything, they are still caring and communicating with compassion, even in very challenging. So I cannot say enough good things about them. So moving on, but they deserve everything we can give them. So this is our 2 South day room, just kind of part of the surge where we took a meeting room, converted it into patient care space. We are not at this point using it. We are prepared if we have to. So next slide. This is Dr. Creighton. She's one of our hospitalists who's also been just kind of a champion throughout the process and has spent a lot of time with COVID patients. She's the main leader on the 2 South floor for adult patients. And she was the one back in April, May, and she had made this statement that got picked up a little bit. You know, this place is on fire with COVID. And I've just heard it since then as a reference that it's been translated into this reference of sometimes some clinicians and other places have felt like the house is burning and everyone else like just walking on the sidewalk, just ignoring the house is burning. So anyhow, Dr. Creighton, can't speak enough good things about her either. So our pediatrics, you want to take this one, Michelle?
So the difference we've seen with pediatrics is this Delta variant has made much more of an impact on the youngers than it has in previous variants. And so as a pediatric department, we have 8 pediatric rooms. We do not have a PICU. So anyone who gets more severe illness of any kind gets shipped to Anchorage. And we have shipped kids to Anchorage as a result of complications from COVID already. So we have also admitted kids as young as infant in the first few days of life to as old as 17 and 11, 12. I mean, they're in that pediatric group. We're seeing it across the board and it is there. And so they too have been more and part of our population of people who are affected by COVID more so now than any other time in the pandemic. And it's not just a Fairbanks isolated thing. We're seeing it around the state and we're seeing it around the country as well.
Next slide. More heroes. Our own Dr. Nace. So sorry to embarrass you there. And Dr. Bruner. Moving on. Wow, Michelle, you didn't want any kudos? But seriously, we are very fortunate to have both of them. Michelle's been working with the school district and Laura's been trying to, again, the protocols that have to be put in place, you know, take care of, as that cup says, the tiniest of humans. It's not, you know, everything's different in kids and figuring out what applies, and there's no literature and everybody's learning and you're trying to figure it out as you go. It's, you know, this is not what, you know, usually we train in school and we kind of learn and then we learn on the job. And this is, everybody's having to try to keep track of the science and experiences and all that at the same time. And that's been more so challenging for, I think, the pediatric population than anywhere else. Next slide. So our ER, been busy. Most of we are still seeing a high volume of patients. We are seeing a high acuity of patients. We are seeing heart attacks, strokes, behavioral health issues, as well as COVID. And it just feels like we're seeing more and more. We have added those chairs, as I spoke to, when we've had long wait times. So we've not gotten up to that 3-hour wait again. And so that process is triggered if we're starting to reach wait times of an hour or 45 minutes, then we trigger that. We've been hiring paramedics to help in a new role. And so that's been working out really well. Next slide. These are some of our ER physicians who've been part of our group in terms of trying to, Mark Simon has been doing a lot of messaging with the community. And Dr. Conklin is serving as our chief of staff and been working on protocols, as Dr. Burton, who's medical director of our ER. And again, working on trying to, at all times, how do we make this work for everybody so that we stay safe as well as effective, as well as customer service oriented. Next slide.
Angie?
Yeah.
Hold on, sorry, Jeff.
The big question, Angie, whose baby is that Mark's holding?
I have wondered the same thing. I have not yet asked him. You don't know, Michelle, do you? I won't go there. So we already kind of covered this. So in the interest of time, we'll kind of move on, but we work as a system. Outpatient area, just really want to call out first care. We've had wait times of up to 4 hours routinely now. It's really been how we've gotten this far, this long, is that we have worked together as a system. And so the lower acuity patients have gone to first care and the higher acuity have gone to the ER. As I participated with calls across the state, the systems that have not had such tight relationships with urgent care clinics have struggled because their ER is busy with that high acuity patient, but it's still busy with a lot of the lower acuity patient as well, which has created challenges for them that we have not had to face. So lots of kudos to them, but they've been in the thick of it. And then these are just some of the other clinicians who've been really instrumental in kind of helping us kind of keep the ship together. And I can tell you, those are each moms of their, and those are their own kids that they're with. So next slide. So just a reminder that COVID, a lot of people think about themselves, and but it really has impacts on hospital capacity and healthcare as a whole, which we've kind of touched on a little bit. That a lot of people don't realize that, but we're seeing the strokes and PEs on a regular basis. We've had 2 inpatient strokes now. When I say that, I mean 2 patients who've been admitted for COVID and being treated for COVID pneumonia who developed strokes in-house. So again, there's just a lot of impacts that there's just not been a whole lot of time to share or learn about. Long COVID, also very similar. We could keep going. Healthcare worker impact, another huge that I think we're going to be living with as a national healthcare system for a long time. This is just very different than any other condition that we've treated, and that and just kind of the impact on healthcare workers in something that's so sustained is just, I would say, unprecedented. And so whatever we can be doing now to take care of our healthcare workers is going to help protect us having a healthcare system for the next decade. Next slide. So I just wanted to touch on this briefly. So we enacted the crisis standards of care, and there's a lot of, well, there's some headlines that I really don't care for about this, but that's the nature of headlines at times. But the basis for our decision to move to crisis standards of care was that the difficulty in transfers, and so that we are at times keeping people here that we don't feel is standard of care. A standard of care would be that they are in a place either managed by specialists, or even if we could manage them, they're at risk for a complication, and you're better off being in a location where that complication could be handled. We have been fortunate to date that we have not had any bad outcomes, but just knowing that that is always a risk. The fact that we've been operating at capacity, and in particular this past week, where we are now having to make decisions about what services to provide on almost a daily basis, as well as the limited quantity of monoclonal antibody and having to restrict that for the highest need patients. Next slide. So the benefits to our organization, which then translates into benefits for patient care, is clearly messaging that it's different now in terms of how we do care, and kind of trying to get that message across by the state doing the statewide activation, and that we are a part of that. We have limited liability, which again, in legal speak, this is a state process. And as long as we follow the state guidelines for how we allocate scarce resources, any liability to managing that is at the state level rather than at the individual level. And then it removes the burden. Clinicians are all trained to take care of the patient in front of them in the absolute best way possible. And so this removes that decision-making burden from the frontline clinician, and that there's a formal process for how those decisions are made. Next slide. I'm not going to go into details here. The point of this being here is conventional standards is what we all know, routine care. Contingency standards are what we've been engaged in this past year, where it may look different, happening in different places. But, crisis standards of care is that next phase that we have entered. But it's a continuum, and it doesn't mean that you stay in crisis forever. The easiest example is the monoclonal antibody. We've had to restrict that, but as soon as the supply expands, we'll be able to expand that. And so it doesn't mean you're there forever. The big change in terms of these different standards of care is that I think with crisis standards of care, the aim of care changes from focusing on the individual patient into how you make decisions on how to use the resources for the best for everybody. And so again, using the monoclonal as an example, if it was on the individual patient, we would give it to everybody who met the EUA requirements until we ran out. But knowing that that was a scarce resource and running out is not the best thing for the community, we limited its use to those who would most benefit using guidelines. So it was done in an equitable fashion, not just our favorite person or our next door neighbor, but by the population that would benefit the most from not getting hospitalized, et cetera. And so it just changes how you do things. It's more by protocol as opposed to the individual patient in front of you. Next slide. So again, this just highlights the ethical obligation, and at this point in time, with it being so tight on capacity, that you have to make decisions in terms of what's best for the community. I think this is the most important slide that I wanted to share, and just kind of really wanted to emphasize this in terms of what you as an individual may experience. You may not see a difference at all when you come in. We are still here. We are still providing care. We are still doing the best we possibly can. But you might have a procedure or surgery that's put off, whereas we usually wouldn't do that. You might have a trial where usually in the past, we might have admitted you right off the bat. We might try you with outpatient management with very close follow-up, of course, to see if that worked. Or we might discharge you from the hospital a little bit earlier, again, with very close follow-up. But those are things that we routinely would not do. But when we have the capacity issues that we have right now, we may have to do. So I am very hopeful that for most patients, you may not experience any difference at all, which is why the message has to be still come to the hospital. We do not want anyone to be afraid to come. That said, it needs to be clearly understood that things may be a little bit different for a while, and actually more than a little bit different. And that we're making those decisions in a fair and equitable fashion for the good of the whole. I think that's it for me. Yes, and at this point, I was going to turn it over to Dr. Nace. I did just want to take a pause because I am going to have to step off. I am so sorry. But if there was any questions around the crisis standards of care piece, because I think the media likes to talk about rationing care. And I cannot say that that's not ever going to happen, but that is not at all the point.
Jomo, just on the development of the vaccine, if any of you haven't read it, a great book is The Code Breaker by Walter Isaacson. It tells the whole story of the development of these vaccines and focuses around Dr. Jennifer Doudna, who got a Nobel Prize. But yeah, COVID-1 was back in 2002, and even prior to that, the development of the vaccines. It's an incredible story, but I'd highly recommend The Code Breaker by Walter Isaacson.
Cool.
Thank you. Well, while we do have Dr. Ramirez for a moment, I would offer, if anyone has any questions for the information up to this point, please just feel free to take yourself off mute. Okay. Well, Dr. Ramirez, I just do want to give you my my heartfelt thanks both for this presentation, but again for all the hard work you all are doing over at FMH for our community. It's been a hard 18 months. We have a harder time ahead of us yet to go. But again, you all's efforts have been exemplary, and we certainly here in this shop we know that you're doing the absolute best you can for our community. So thank you so much.
Thank you for sharing that. We have a great community, and I think, yeah, thank you. And I'll turn it over to Dr. Nace. Thank you.
Thanks very much. And I just wanted to give a shout out for Dr. Ramirez. She has been a leader, and in this time period, when we look for someone, we need an answer, we need it now, and we need it to help community. She's the turn to, and she has a big and she has done an absolute phenomenal job with helping parents and the state be able to do what we can do. So a huge shout out to her, just as you said. So what I'm going to present is just to give some state data, and I know that the time is not. I'll do it. If there are questions at the end, sure, just let me know as well. But just talking about what's going on. The top one is what's going on in the United States, and you can see everybody's has been asking the question, when is Delta when are we gonna see the downswing on it? And in part of the United States, good news is they are seeing that a little bit. The numbers are going down, but in Alaska, we have not quite yet had that. We are still going up. And so if you look on the bottom one with the pink lines on the blue, that is Alaska. Some of the ones that we are seeing down is just because the data is not up. But if you look on a day-to-day basis, week to week, we have not yet had that over the top, and we're hoping for that to come. That's where we're depending on our community to help. So this is another way to look at the data dashboard. And that what this shows us is the current number of cases that we are having. And so again, you'll see that very last pink line. These are the number of cases. The only reason why that number is down is we have not got all the cases just yet in. And we're still going on our upward trend, and we hope to see that improving. The yellow bars is the number of hospitalizations by month. And so that last bar is just tiny because we're only a few days into October. We are still seeing strong numbers in our hospital. Currently now, about a third of the patients that we have in there are related to COVID. And deaths too, where our deaths are at all-time highs from where we've been from a month-to-month standpoint. Can you guys still hear me?
Yes. And you're on the next slide.
Yeah, the slide didn't go. Did it advance for you, or are you still seeing the same?
Actually, right now we're seeing deaths, hospitalizations, death, Alaska.
There he goes. Okay. So what the purpose of this slide is to show who is making up those cases. And just to point out one of the differences, if you look at the colored slide with the blue on it, that blue is those kids. Those are those under 18 and younger. And so what that is showing is that that blue line is taking up, as well as that group from 20 to 39, which is red. Back in the summer, we were seeing such a small population of those being those younger groups, meaning under age 40. And over time, they are taking up a bigger portion of that from the kids, from the middle kind of age group, as well as still seeing some in the older. But why that's significant is those are the parents. Those are the parents of those kids. So a different population in the hospital than we've been seeing in the beginning of the pandemic. This slide points out vaccination. And again, excited to see that we're above 60% here in Fairbanks. That is nice to see. But still would like to see that number get even higher. So this shows residents 12 and over, how many we've seen fully vaccinated, and then we have 61%. If you include those 12 and younger though, we are still just right at there at 50% of our entire population. So. I don't have it advancing to the next slide, but it'll catch up with me. The next slide that we'll be talking about is the messenger RNA virus recommendation for those who are immune compromised. So that is truly a third dose that is recommended for those who fit in that category. And that might be those who are immune compromised, those who have a transplant. And so we do recommend reaching out to your healthcare provider to get that third dose. Then other shout out would be for those, the booster dose. So that's different than the third dose. So those for the booster dose are recommendations for those 65 and older, and those in residence and long-term care facilities, as well as those ages 50 to 64 who might have a medical condition that is puts them at increased risk. So if you are in that category, we encourage you to get that third dose, and that can be at any place that gives out pharmacies, your medical provider, if they are COVID providers. That is the possibility for you to get that booster dose as of now. The other recommendation and program out there is the Alaska Chamber campaign, whereas if you get your new COVID-19 vaccine, each week they're giving out 2 bonuses of $49,000 to those who have been newly vaccinated. And that's been going on as a weekly, and we've seen lots of pictures represented throughout the state of those who have won that particular $49,000. I know my slides aren't advancing. Can you still hear me though? Give me a thumbs up.
Yes, I still hear you.
Okay. So the other things is like, what can we still do as a city? What can we do as a nation to help present and help our current records? And so what we'd like to see is the same things you've heard again and again is getting vaccinated. Masking is important. Multiple new studies that have shown the advantage of masking. Well, they took masking in schools, the universal masking, those in a recent study that had 75% of the population of Arizona. And they started with Arizona because they started school in July, so they were a good testing base to do that. Compared to schools that had universal masking, those that did not. And if your school did not have universal masking, you were 3.5 times more likely to have to quarantine and have to have outbreaks at your school. So the strong recommendations in those settings is masking does work, and it makes a difference for those. The other thing is testing. If you are having symptoms of COVID that may be consistent with COVID-19, is to get tested. Still important. We do have them. Yep, there have been some longer waits to get it because more people are getting tested, but we encourage you to get tested. The other new recommendations that you've seen about is the CDC recently recommended, put out a health alert for those who are pregnant, who have recently been pregnant or considering pregnancy, is to get vaccinated. Right now, our pregnant population is one of the smallest percentage immunized at only 30%. And we are seeing that. We are seeing that, and nationwide, we are seeing it at our hospitalization. We have currently an incredibly high number of positive moms giving birth both locally and within the state, and that affects not only them but also their child. And we are really recommending it. It is recommended by the CDC, by the Institute for American Academy of Pediatrics, as well as the ones for ACOG, who is the obstetrician gynecologist, is recommended to get vaccinated if you are pregnant or considering becoming pregnant. We're also looking ahead to getting vaccinations for those who are younger, the 5 to 11s. So that data from Pfizer has been released and sent to FDA. The FDA is in the process of going over it right now. We hope to have that recommendation by the end of this month, as early as the end of October, to then have the information available to us to be able to then have an EUA for those ages 5 to 11. So hoping to have a good majority of those age group immunized even before the start of completely before the start of next semester. There are different organizations out there also that are just like what we did here, came here and talked with you. The state has what's called a Speakers Bureau. If any of you are members of a different organization, a group, a workforce, if you are interested in having us come and talk with you about the information you've heard here as well, that is the possibility. You can reach out that through the state and are able to get that. So just in summary, layering your protection using vaccines, masks, testing, continuing the physical distancing, and to maintain that social kind of awareness that COVID is out there and we really want it to go away, and that depends on each of us as individuals to help and work towards. So sorry the slides didn't advance there, but hopefully that will give you some new information regarding out the state, and I'll see if there's any questions before I sign off and turn it back over to you.
Okay, thank you very much. Yes, do we have any questions? Okay, well, I guess I'll just go ahead and lob out a punchline in the form of a question. Some of what I've really, the big punchline I've gotten out of all of this is that our healthcare system is not to the breaking point. It is not broken, but it is highly, highly stressed. And then we need to do a bit more on the citizen side to relieve that pressure. Fair enough.
I would say the reason that you, Fairbanks, we are doing our best to continue to provide the care that we have been used to as a community, fortunate to have the hospital and the support that we do. And it's largely from teamwork from those who work within it and teamwork from our community. And we're just asking to up that game from the community to increase and help and do what you can as members to follow the mitigation strategies to help us keep from saying, yes, we are broken, but we are not broken. We are banding together as a team and doing what we can to keep Fairbanks safe. Jeff, I don't know if there's anything else you wanted to add to that part before we sign off, but that would be our biggest question is like, can you help us? And here's how you can help us.
Mr. Cook?
He was saying he was having some internet issues down where he's at right now currently too. So he might be having a little difficulty with that as well.
Sorry, I'm back.
Please, Mr. Cook.
I'm sorry, what was the question?
Oh, there wasn't a question. I was just seeing if you had any other input before we signed off. I was just telling him that we are not broken, that we are banding together as teamwork within FHP and depending on our company, our community as well, to help us in that, to keep us from being at that point that right now we are stretched, but we are still providing the care because we care about our community and want to be there for them. And the part that they can do is to help follow the mitigation strategies to help keep us where we are now.
No, great. We have a great system, great people. We're doing well. If anybody wants to really help right now to show your appreciation to our staff through the Hospital Foundation, you go online. We have a support our staff fund where we bring them snacks and massages and do other things to really thank our employees. So if you want to help out, go online or donate in any way you want to the foundation. But right now, supporting that employee fund to help our employees would be great. Thank you.
Thank you. That's another good update. So yes. So again, the state has information. Our own Foundation Health Partners has lots of information that's available and accessible online, I believe. Is that correct, Dr. Nace?
Yeah, the community feedback at foundationhealth.com. That's another, .org. You can also go there and just by going to the hospital website, it's easily on there. You can say, hey, what can I do? Or I have this, what can I do? They can help you facilitate how you can help.
So if you want to support our friends and neighbors over at Fairbanks Memorial Hospital and Foundation Health Partners, again, they have a way that you can show direct support by, again, this support the staff link as far as things like again, lunches, other nice things that you can do to show your appreciation. If you have time, if you have a young person who's currently moving Coca-Colas, but maybe would like to get a little experience in the healthcare field and also do a good service for their community, there's some for pay opportunities to more directly show your support to our medical team here at the community. But beyond that, again, the biggest, best things you can do are follow the safety guidelines as not even as instructed, but as you think them through are just absolutely prudent. Social distancing, masking, and just keeping yourselves and your family safe and your friends and neighbors. Dr. Nace, Dr. Ramirez, thank you so much for this presentation. Thank you so much for all of your hard work. Thank you, Jeff Cook, for helping me get in contact with the good doctors so we could have this presentation. And we will be circling around as this progresses, as we have fairly regularly over the course of the pandemic, to try to make sure the public has the best information possible so that we can have the best outcomes we can achieve. So again, thanks everybody so much. And if you haven't already, today's municipal election day, get on out there and vote. All right, everybody, see you next week. And again, thanks, Dr. Nace. Thank you so much.